Welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson. Welcome to part 2 of our skin and hair series with Kate Willis. Today at part 2, we are going to be talking about melasma. Many of you know that melasma is hyperpigmentation of the skin. We often get melasma with increased estrogen levels. So sometimes that happens with birth control pills earlier in life. Sometimes that happens with pregnancy. It can also happen with hormone replacement therapy. And there are some new options for melasma. So particularly, we're going to be talking about tranexamic acid, which has some new data on melasma. And Kate's really going to help us clarify using topical versus oral tranexamic acid for this, as well as some other options to help out. One of the things I love about Kate is that she does a great job about putting together the whole picture. So at the end of this episode, she's going to talk about using compounding to combine many products so we can hit this problem from lots of different directions. I hope you'll join me and enjoy the show. Kate, thanks so much for coming on to talk to us about melasma. I know this is such a frustrating area for many women. Let's start with the basics. For those of you who may not know, what exactly is melasma and what causes it?
Melasma is a tough and chronic pigment condition that's triggered by UV. It can be triggered by heat, hormones, especially estrogen, and genetics. So this is, if you've seen it, you know what I'm talking about. It's these brown, blotchy patches, often on the cheek, sometimes over the lip, maybe on the nose or forehead. And it's really tricky to treat.
I know a complaint I've heard from a lot of patients is that maybe they've invested a lot on laser or skin resurfacing. Maybe they're invested a lot in products to help with melasma, and it gets better and then it comes back.
The reason that it's so tricky is it's not just superficial. So it's epidermal and dermal. So it's in two different layers of the skin. There are also some vascular components. So again, we're not just trying to address the surface of the skin because there's this underlying vascular component as well. So if you've had it, it is really tough and can be really frustrating. And we see it flare sometimes if someone starts birth control pills or if someone is pregnant, and it's a tough cookie to address.
I know that tranexamic acid has been getting a lot of attention recently in dermatology. Can you explain what it is and how it works for melasma?
Yes, I think this is really cool. I was excited to learn this information. This is an antifibrinolytic medication, so it's actually preventing the breakdown of blood clots. And as you mentioned, originally used for heavy menstrual bleeding and preventing blood loss during surgery, but it's in the last decade kind of emerged in dermatology. The reason that this is kind of a novel treatment approach is because it's not just addressing the surface of the skin, which is what a lot of melasma treatments do target. It's actually targeting the vascular component that can drive melasma, and it's also helping reduce melanin production that fuels melasma. So we can use this topically, we can use it orally. So I'm excited about this option as well.
So, Kate, what kind of research do we have on how effective oral tranexamic acid is to treat moderate to severe melasma?
So this is really great in those moderate to severe cases. Again, we think there may be more of a vascular component when melasma is falling into that moderate to severe category. There was a randomized control trial that showed taking 250 milligrams for twice daily for 3 months led to a 49% reduction in melasma severity, and the placebo group only had about an 18% reduction. So that's a pretty decent improvement overall. And then even after stopping medication after those 3 months, most patients retained significant improvement in their skin. So I found that really encouraging. There was also a meta-analysis. So meta-analysis is looking at multiple randomized control trials and summarizing the findings. And it looked at 6 different trials, and they identified the most effective dose was 750 milligrams per day. So 250 milligrams given 3 times daily appeared to be the most effective dose. They did find that dosing twice daily, so 500 milligrams total per day, works, but it's just slightly less effective. So 750 milligrams total daily dose appears to be the most effective dose.
Since tranexamic acid is used in other areas of medicine, right? We use it in gynecology for heavy menstrual bleeding. Can you talk a little bit about risk associated with this medicine, particularly blood clots and safety, thinking about blood clot risk like deep vein thrombosis, pulmonary embolus, those kind of concerns?
Yes, I've had a handful of patients for whom I've prescribed this for heavy periods when we've done other interventions that haven't been as successful as we would like them to be. And that's one of the first questions that I get is, am I going to get a blood clot? So first, if you're healthy, this is an extremely safe drug. So very low risk of having a blood clot. So what are the other things that increase our risk for a blood clot? Family history or personal history of a blood clotting disorder, being overweight or obese, being sedentary, having major surgery. So interesting, we actually give this sometimes during surgery to help prevent bleeding during surgery or post-operative bleeding. So it can be actually therapeutically used in that space. But for a healthy individual, the risk is very low. I would say this is a great place to have a conversation with your prescriber to see, do you have any risks that they're concerned about? Do you have any red flags? And most people, again, this is going to be a really low risk option.
So if someone's listening and they hear these risks, albeit low, a low incidence of risk with tranexamic acid, the consequences of being one of the few that might happen to can be a really big deal. So maybe folks listening might thinking, is there another way to use tranexamic acid without taking it orally that might be lower risk? So can you talk to us about a comparison between oral and topical tranexamic acid?
Well, first, circling back to the oral, this is not a long-term medication. So this is like 12 weeks. So I think if you're really battling severe melasma, oral is hands down going to be more effective than anything you can use topically. So I think it's worth considering. Obviously not for everyone, but it is short-term, quite safe, and more effective than topicals. So topical studies showed modest improvement with reduction in pigmentation and that vascular activity. It's used in concentrations between 2 and 5%. So that obviously will make a difference too. It can be a little bit irritating when it's at a little higher percentage. But one study showed some effectiveness for that kind of mild to moderate melasma, but not statistical significance for those with more severe melasma. So I think that's just something to keep in mind, is that oral and topical are going to have a real difference in their efficacy, and then the tolerability issue. But I do think it's worth it, especially when if you're combining products for melasma. I think this is a great place to bring in the topical as well.
So while we're talking about combination therapies, we've established that melasma is a fairly challenging condition to treat. It's something that a lot of people are going to struggle with their whole lives. So many women are often going to be looking at layering together different treatment modalities, particularly if early, more first-line treatments haven't worked for them. So I'd love it, Kate, if you could tell us a little bit about combining tranexamic acid with other therapies like hydroquinone, trinitoin, corticosteroids. What's your experience with this? How can this improve outcomes?
Yes. So there's a triple combination product that has hydroquinone, tretinoin, and a corticosteroid for melasma. And interestingly, we do have some data that using that alongside oral tranexamic acid therapy reduces that pigmentation even more than oral alone. Um, but we can add that topical into this combination. I don't want someone using a corticosteroid on their skin long term, but the tretinoin, the hydroquinone, and the TXA could possibly be used in combination longer term to help with maintaining benefits if someone has, especially if someone's treated melasma, maybe with an oral medication or has, had lasers or something like that. I think it could be a great option for maintenance.
One thing I'm thinking about as I'm listening to myself list off the litany of the many, many things we could add on is this sounds like a lot of work, and we've got busy lives, we've got a lot to keep up with. So, what about cycling on or off treatments? Can we offer patients maybe a drug holiday?
Cycling off and on treatment. So again, if maybe someone has had more severe melasma and has treated it and it's in a better place, you can sort of cycle off and on these to help with some of the maintenance of the benefits that you've already gotten for your treatments.
So this is something we've touched on already a little bit, but once someone treats their melasma successfully, does it tend to come back? I know in OBGYN residency and training and experience, the thing I think of melasma is pregnancy. The mask of pregnancy is kind of what we call it. But Kate, can you clarify for us other specific triggers outside of pregnancy where hormonal fluctuations or maybe even other triggers like sun exposure that folks should be aware of?
So we think that we're maintaining benefits if triggers are avoided. So if someone's trigger is birth control pills and they go back on birth control pills, I think there is a possibility of recurrence. Now, it depends on, someone's own setup for what their trigger is. So if you took birth control pills and you were out in the sun a lot, in your 20s, that together may have been the trigger. So it may be that a hormone by itself without the sun exposure piece of things won't lead to recurrence of melasma. But I think it's depending on someone's individual triggers. It's depending on sunscreen again is a big important piece of preventing melasma recurrence. Hormone shifts. If someone gets pregnant and is prone to melasma during pregnancy, it may recur. If someone's on hormone therapy and is very melasma prone or is using topical estrogen. So I think this is going to be a case by case basis in terms of, prevention. Sunscreen is really key, but does someone need to maintain cycling off and on of a topical to maintain benefits? I think that's pretty individualized at that point.
We've talked a little bit about side effects with tranexamic acid taken orally. There's a small risk of blood clotting. A blood clot that is in a vein, a deep vein would be like a DVT. If that breaks off and goes to your lungs, it can become a pulmonary embolus that can be very serious and life-threatening. So we want to be really mindful about that. Other less severe side effects might be things like hair loss, which is a huge concern for midlife women. So can you talk to us a little bit about how common hair loss is as a side effect and if folks should really be concerned about that?
Some women do have reversible hair shedding, so we don't think this is going to cause permanent hair loss, but it's sort of falling into that category of that stress-induced hair loss. And so it's not a super common side effect, so I don't think you anticipate that this absolutely will happen. In most cases, it resolves after someone stops the medication. So I think it's something good to have on your radar to see if it happens to you. And again, we're using this short term when we're using it orally. So we're not this isn't something that you'll need to be on for years and years to see an effect on melasma. So hair shedding can happen, not very common, doesn't happen to most people, and it appears to be reversible once you stop the medication.
If someone is kind of on the fence and they are thinking about considering this, are there ways that patients can track or document their hair loss or the possibility of hair loss during treatment?
It is hard to monitor. I mean, we actually need to lose a lot of hair to see visible hair thinning, but I think if you are pulling back hair, looking at particular areas where we might shed, and the hair loss with this tends to be more all over. So someone might notice more hair in the shower drain or more hair in their hairbrush, as opposed to specific thinning. But certainly stress-induced hair loss can uncover that hormonally driven hair loss. So I think finding a way to quantify or document hair status over the months of treatment could be a really great idea.
So we've talked about layering therapies. We've talked about oral versus topical tranexamic acid. We've talked about sun protection. Maybe you could help folks a little bit if they're, hearing all of these options. A common question is, where do I even begin? Where do I start? So, can you talk to us a little bit, since we've also clarified there are some risk with oral tranexamic acid, when you would consider that? Is that something you would go to right away, or would you start with other topical treatments first?
Yeah. So, I think if you failed other treatments, this would be a great option to consider. So, if you're naive to other treatments, I would reach for some pretty commonly used topicals for a while. So, Triluma is a brand name. It's the hydroquinone, tretinoin, corticosteroid combination. That's very effective for melasma, and that's topical with fewer side effects. And so that's probably where I would go first, is something topical. And then if we're getting stuck or someone hasn't had full resolution of that, then I would opt to move to oral tranexamic acid.
And then again, just to clarify for folks, are there certain patients that we would never want to use tranexamic acid on? So specific red flags or contraindications there.
Yes. So history of blood clot or blood clotting disorders, especially a non-provoked blood clot, so one that didn't come from, maybe surgery and then a flight across the country or something like that. Stroke or cardiovascular disease, those would be things that in my mind would be red flags. It appears that this is safe to use with smokers, but I would be really cautious. I don't think I have any patients right now who are smokers though, so that's probably not something that I'm as worried about, since it's not showing up in the patients that I see.
So some of our tranexamic acid is sort of the new option for melasma. If we kind of go back and look historically at what we've used, we've often used hydroquinone as something to help with pigmentation or hyperpigmentation. And that hydroquinone's been called the kind of gold standard for melasma. So let's kind of go back and think about what are our basic treatments. Can you talk a little bit about hydroquinone, how it works, and if you were still calling that the gold standard today?
Hydroquinone is it's been around for a long time for melasma. It was considered the gold standard for a long time. And it works by inhibiting the main enzyme involved in melanin production. You can see effects in 4 to 8 weeks. It is primarily addressing that epidermal dermal component, not the underlying vascular component. So it's good at the more superficial melasma. It can also be irritating to some people's skin, and so that's why that triple product has the corticosteroid in it, is it's providing some of that calming effect. So I think the current thought is that hydroquinone is really best used in combination with other products for superior results, but also for tolerability. And then that's where we're getting that Triluma, that triple combo cream, the hydroquinone, tretinoin, and corticosteroid. It's working better using hydroquinone all by itself.
Another one of our sort of tried and trues would be Triluma. And so it's a triple combination cream. Maybe you could tell folks a little bit about cost and insurance coverage with this option.
I don't know, just because I'm not currently working in that space where I'm prescribing that brand name a lot. And so I don't know currently if insurance is covering it or if it's available as a generic right now. But that certainly would uh, make me pause if it was going to be a really expensive product for someone. And the truth is, you can prescribe hydroquinone by itself, and that would probably be a pretty affordable option. And you could do a tretinoin, so you could do these separately if the cost is prohibitive, or use a compounded option as well. I just looked this up on GoodRx, the Triluma, and with a GoodRx discount, it's $244. And a tube will probably last a couple of months for most people. So not cheap, but not $1,000. So I think, you'd need to see if your insurance covered this. There's not a generic available at this point. So
If cost is an issue, are there more affordable alternatives or is compounding an option for Triluma?
yes. So there are a couple over-the-counter options: niacinamide, vitamin C, azelaic acid that you can get over-the-counter strength and a prescription strength. They can be helpful kind of as add-ons, but they're really not considered mainstay for melasma treatment. They're not going to perform as well. So if you have anything beyond mild, kind of superficial melasma, I would consider using some other some prescription products versus what's available over the counter. But then you can add things like niacinamide in. Niacinamide is going to help with tolerability. So sometimes we can throw that into a compounded option to help with the skin barrier and tolerability as we treat melasma or something else.
So we alluded to this. Sun exposure is a big deal when we think about melasma. And we can't talk about melasma without talking about sun exposure. So talk to us a little bit about sunscreen for prevention and maintenance.
Sun protection is really important. I'll say that probably every time I talk about the skin. Photo aging, the aging that we get from the sun is one. We just age and our skin changes because we age, but sun accelerates that. So sun, is important. Sun protection is going to be important for lots of things. But in this area where we're really dealing with something that is going to be sun responsive for many people, please use your SPF. Use a mineral based versus a chemical based. A chemical based sunscreen is going to degrade pretty quickly. So if you put that on in the morning, you probably don't have protection when you go outside at lunchtime. So, for a number of reasons, sun protection is important, but specifically with this very responsive condition to sunlight, it's especially important. And put it where you're prone to melasma. So if you're, putting your moisturizer or your daily SPF, on your cheeks and your forehead, but you're prone to melasma over your lip, you're not going to get any protection. So make sure you are applying it in the areas that you are particularly prone, if this is an issue for you. The dermatologist I worked with used to say the chest doesn't lie, because a lot of us are really good about, skincare and sun protection on our face, but we're not really addressing our chest, which isn't usually a very melasma prone area, but certainly needs sun protection for other reasons too. So
I'm really glad you mentioned making sure people are protecting their chest, because I know that's where a lot of us, as we're noticing our skin is changing and we're aging, it's kind of one of those areas where maybe we're doing a really good job with facial sunscreen, but maybe not so much with V-neck t-shirts and those kind of things, where we're kind of noticing where the areas we've missed, they're showing up. So it's a great reminder to make sure you're sort of treating from your sternum up to make sure all of that gets really, really good coverage. Thanks so much for going through melasma with us today, Kate. I hope this has given some folks some really practical tools, a little bit more information, and maybe hopefully being able to go into the dermatologist or primary care so that they're aware of newer options and aware of older options, as well as being aware of things they can simply buy over the counter that can help with this. I think my big take home from melasma is that it's not one and done. This is something that if you have melasma or you're prone to it, you are going to need to protect yourself against forever and ever. And so we really want to have that long-term mindset where this is something you're protecting yourself against. We're not in the mindset that we're going to fix it and it's going to be gone. That's where I think we can generate a lot of frustration and where I've seen a lot of patients be frustrated. And so if you're doing something, if you're making an investment like a laser or something like that, this is going to be something that you're going to need to do ongoing, either follow it with medical treatment, follow it with over-the-counter treatment, but you're going to need to continue treatment because it's not a one and done problem. Thanks so much, Kate, and thanks everybody for joining us.
Lots of fun. Thanks.
Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.